Welcome to the deep dive. Today we're tackling neutropenia. It sounds a bit technical maybe, but it's super important for understanding how our bodies fight off infections.
Absolutely.
Basically, it means your count of these key infection-busting white blood cells, they're called neutrophils, has taken a dip.
Exactly. And, while maybe it's not a household name, getting a handle on the basics of neutropenia is really useful. It kind of shines a light on how your immune system is working away behind the scenes.
Yeah, protecting you from bacteria and things.
Day in, day out.
Couldn't agree more. So think of this as your, let's say, quick but comprehensive guide. We're going to break down everything from what it actually is to why it matters, without getting too bogged down in jargon.
Keep it clear.
Right. Our goal today is simple. Just leave you with a clear picture of neutropenia, what causes it, what the implications are. Okay, let's jump straight in. What exactly is neutropenia?
Okay, so, at its heart, neutropenia just means you have a lower than normal number of neutrophils in your blood. And these neutrophils, they're like the real workhorses when it comes to fighting off bacterial infections. Really essential.
Okay, so lower than normal, but what does that actually mean number-wise? Like, what's the typical ballpark?
Good question. Generally, a normal absolute neutrophil count, we call it the ANC, is somewhere between 2.0 and 7.5 times 109 cells per microliter of blood. Neutropenia is, officially defined when that ANC drops below 1,500 cells per microliter, so 1.5 times 109.
And it's not just like on or off, is it? There are different levels, different severities.
Precisely. Yeah, we actually categorize it based on just how low that neutrophil count gets.
Yeah.
So if your ANC is between 1.0 and 1.5 times 109, that's generally considered mild.
Okay.
Moderate neutropenia is when it's between 0.5 and 1.0 times 109.
Right.
And then when the ANC falls below 0.5 times 109, that's severe neutropenia.
Wow, okay.
And yeah, that's a severe point. Even something seemingly minor, like a small cut, could potentially lead to a pretty serious infection quite quickly. Your body's main bacterial defense is just significantly weakened.
Okay, that makes sense. So we've got the definition, the different grades. Now, what actually causes this drop? It sounds so fundamental. What can throw it off?
That's a really key question. And the reasons, they're quite diverse, actually. You can think of it like this. Either something's messing with the bone marrow's ability to actually produce enough neutrophils.
Okay, the factory isn't working right.
Exactly. Or the neutrophils that are being made are getting destroyed too quickly out in the bloodstream or elsewhere.
Right.
Or, thirdly, they might be getting sort of trapped, sequestered, maybe in the spleen or somewhere, so they can't circulate properly to do their job.
So multiple ways it can go wrong.
Yeah, it really highlights how interconnected everything is in the immune system.
So what are the main sort of buckets or categories of things that cause this?
Okay, big picture, we're looking at bone marrow disorders themselves, chemotherapy, that's a really well-known one.
You hear about that?
Autoimmune diseases, certain viral infections, some medications definitely, nutritional deficiencies, and even some genetic disorders. Wow, quite a range.
It is.
Yeah.
Sometimes a little mnemonic helps. Maybe something like bad CV MNHRG.
Okay, let's hear it.
Bone marrow, autoimmune, drugs, chemo, viral, medications. I know drugs and meds overlap, but helps the letters. Nutritional hemodialysis, we'll touch on that, rheumatological, and genetic.
BAD, CV MNHRG. Okay. A bit silly, maybe, but could actually stick.
Hey, whatever works for recall.
Exactly.
Yeah.
Can we dive into some specific examples, make it a bit more concrete?
Absolutely. So when we talk about viral causes, think about things like HIV, Epstein-Barr virus, that's the one causing glandular fever or mono.
Right.
And various types of hepatitis can also do it.
Okay. And drug-induced. You mentioned chemo.
Yeah, chemo drugs, those cytotoxic ones, are a major category. But also other meds like carbimazole, which is used for hyperthyroidism.
Oh, interesting.
And clozapine, an antipsychotic medication, is another one known for this risk.
Okay. What about that benign ethnic neutropenia you mentioned earlier? That sounds quite specific.
It is. Yeah, and it's a really important one to know about. Essentially, benign ethnic neutropenia is a condition where individuals, typically of Black, African, or Afro-Caribbean descent, just naturally have lower neutrophil counts compared to, say, Caucasian populations.
But it's benign, so no extra risk.
Exactly. Crucially, they don't have an increased risk of infection because of it. It's just their normal baseline. So it's vital for clinicians to recognize this so it's not mistaken for a pathological problem needing investigation or treatment.
That's a really, really important point. Avoids unnecessary worry and tests.
definitely.
Okay, what other significant causes should be on our radar?
Well, thinking about blood disorders themselves, hematological malignancies, things like myelodysplastic syndromes or MDS and aplastic anemia, these directly hit the bone marrow's production line.
Right, affecting the source.
Exactly. Then you have rheumatological conditions like SLE, systemic lupus erythematosus, and rheumatoid arthritis. Those autoimmune processes can sometimes target neutrophils. And then there are other serious situations like severe sepsis, overwhelming infection itself can sometimes paradoxically lower the count, and even hemodialysis for kidney failure can sometimes be associated with changes in neutrophil levels.
Right, okay. That gives us a much better sense of the why. Now, are there specific things that might make someone more likely to develop neutropenia? What are the risk factors?
Yeah, definitely things that increase the risk. Undergoing chemotherapy or radiation therapy is, as we said, a major one. These treatments often damage those rapidly dividing cells in the bone marrow where neutrophils are born.
Makes sense.
Having a pre-existing bone marrow disorder, like the ones we mentioned, or an autoimmune disease, also puts you at higher risk.
Okay, logically follows from the causes. What else?
Taking certain medications, again, the ones known to potentially cause neutropenia, that's a clear risk factor. Also, sometimes experiencing a viral infection can trigger a temporary dip.
Ah, so the infection itself can be a risk factor for a period.
It can, yeah. And finally, a family history shouldn't be ignored. If there's a pattern of neutropenia or related blood disorders in the family, that might suggest a genetic component.
Okay. So useful for people maybe undergoing chemo or with autoimmune conditions or even just after a bad viral infection to be aware of this possibility if they start getting frequent infections.
Exactly. Forewarned is forearmed, you know?
So we know what it is, the causes, the risks. Let's go a level deeper biologically what's actually going wrong, the pathophysiology.
Right. So it boils down to those three main mechanisms we touched on earlier. First, you can have reduced production in the bone marrow. The factory's output is just too low.
Okay. Damaged factory or lack of raw materials.
Pretty much. Chemo damages the factory.
Yeah.
Nutritional deficiencies like severe B12 or folate deficiency could be like a lack of raw materials.
Got it. Second mechanism.
Increased destruction. The neutrophils are being made okay, but they're getting destroyed too quickly once they're out in the circulation or tissues.
Like in autoimmune conditions?
Exactly. The immune system mistakenly attacks them. Certain drugs can also trigger this destruction.
Okay. And the third one was sequestration.
Yes, sequestration. That's where the neutrophils are produced, they get into the bloodstream, but then they get trapped somewhere, often the spleen, especially if the spleen is enlarged for some reason.
So they're made, but they're not available to fight infection.
Precisely. They're not in general circulation where they're needed. And remember, the specific mechanism depends entirely on what's actually causing the neutropenia in the first place.
Okay, this is fitting together nicely. Now, if a doctor sees a low neutrophil count on that blood test, the FBC, what else do they need to think about? What's the differential diagnosis?
Good point. A low neutrophil count doesn't exist in a vacuum. It's crucial to consider other conditions. For instance, are other blood cell lines affected? Is there also anemia, low red cells, or thrombocytopenia, low platelets?
Right, seeing if it's part of a bigger blood picture.
Exactly. That might point more towards a primary bone marrow problem affecting all cell lines.
And what about conditions that might just have similar symptoms even if the blood counts are different initially?
Also key, you need to differentiate neutropenia from things that cause similar symptoms, like recurrent infections. So simple recurrent viral infections need to be considered. Is it the virus causing a temporary dip, or is there an underlying neutropenia making the person susceptible?
Tricky distinction sometimes.
It can be. Also, symptoms like fatigue or mouth ulcers could be from the neutropenia-related infections, or they could be direct symptoms of an underlying autoimmune disease or even a malignancy. So you have to consider those primary conditions too. It requires careful clinical assessment and investigation.
Okay. So how common is this condition overall? What's the epidemiology?
Yeah, the exact prevalence in the general population isn't perfectly clear. Mild cases might easily go unnoticed if someone isn't getting sick often.
Right.
However, we know it's much, much more common in specific groups. The big one, as we've said, is people undergoing chemotherapy or radiation for cancer.
That's where you see it most often.
By far. Because those treatments, by design, affect rapidly dividing cells, and neutrophil precursors in the bone marrow are definitely in that category.
Gotcha. Okay, so we know who's most at risk. How might neutropenia actually show up in a person? What are the clinical features?
Well, here's the interesting thing. Neutropenia itself doesn't usually cause specific symptoms directly. You don't feel your neutrophil count being low.
Oh, okay.
The main clinical impact, the main feature, is that increased risk of infections. That's how it usually manifests.
So it's all about the consequences.
Pretty much.
Yeah.
Think of neutrophils as your bacterial police force. Fewer police on the streets means more crime, more bacterial infections. So the presentation is typically recurrent infections or perhaps unusually severe infections from common bacteria.
Okay. And what kind of infections or symptoms should make you think, could there be underlying neutropenia here?
Common signs would be things like frequent fevers, chills, a really persistent sore throat that won't go away, painful mouth ulcers that can be quite characteristic sometimes.
Mouth ulcers, noted.
Yeah. Also skin infections like boils or abscesses that keep coming back or are slow to heal. And more serious things like pneumonia. Basically, any sign of bacterial infection, especially if it's happening more often or more severely than expected.
Right. The pattern and severity are key clues.
Exactly.
Okay, so if those features raise suspicion, what are the next steps? The investigations.
The absolute first step, the cornerstone, is the full blood count, the FBC.
The basic blood test.
Yep. That gives you the numbers for all the blood cells, including the neutrophils. And crucially, it allows calculation of the absolute neutrophil count, the ANC. That confirms the diagnosis and tells you the severity, mild, moderate, or severe. Remember that 1,500 cells microliter threshold.
Got it. FBC first. What else?
Usually a peripheral blood smear examination goes along with it.
Looking at the cells under a microscope.
Exactly. Someone actually looks at the blood film. The appearance, the morphology of the neutrophils and other blood cells can give really important clues about the underlying cause. Are the cells looking abnormal? Are there immature forms? That kind of thing.
Hints towards the why.
Precise.
So, the FBC confirms if there's neutropenia, the smear gives clues. What if you need to dig deeper to find the definite cause?
Then further tests are often needed. If a bone marrow problem is suspected, like reduced production, then a bone marrow biopsy might be necessary.
More invasive.
A bit, yes. It involves taking a small sample of bone marrow, usually from the hip bone, to examine the marrow's cellularity and look for specific abnormalities like leukemia or aplastic anemia.
Okay. Other tests.
Genetic testing might be relevant if a congenital or inherited form of neutropenia is suspected based on family history or specific features. And if an autoimmune cause seems likely, then an autoimmune panel blood tests looking for specific autoantibodies like ANA or rheumatoid factor would be ordered.
Right, tailoring the test to the suspected cause.
Exactly. It's a stepwise process.
So once you have a diagnosis and hopefully an idea of the cause, how is neutropenia typically managed, particularly thinking about UK practice?
Management really focuses on a few key areas. Firstly, and most importantly, if you can identify an underlying cause, you treat that cause.
Makes sense. Address the root problem.
Right. So if it's drug-induced, you stop or change the medication if possible. If it's due to an autoimmune condition, you treat that condition.
Okay. What about boosting the neutrophil count itself?
That's the second part. In certain situations, especially severe neutropenia or neutropenia caused by chemo, we can use growth factors. The main one is called GCSF, granulocyte colony stimulating factor.
GCSF, what does that do?
It's a medication, usually given as an injection, that stimulates the bone marrow to produce and release more neutrophils, helping to shorten the period of severe neutropenia.
Okay, helpful in high-risk situations.
Definitely. Then a huge part of management is dealing with infections. Any sign of infection, especially fever, in someone with significant neutropenia is treated as an emergency, usually with broad-spectrum intravenous antibiotics promptly.
Treat infections aggressively.
Absolute critical. And finally, there's supportive care focused on preventing infections in the first place. Things like meticulous hand hygiene, avoiding contact with sick people, sometimes prophylactic antibiotics or antifungals, in very high-risk cases.
Prevention is key too.
Very much so.
Okay. What about the long-term outlook? Is the prognosis generally good or does it vary a lot?
It really, really varies. It's almost entirely dependent on the underlying cause and whether that cause is reversible or manageable, plus any complications that arise.
So no single answer?
Not really. If it's, say, temporary neutropenia after a virus, the prognosis is excellent. It just gets better. If it's related to chemotherapy, it usually resolves once the chemo cycle finishes, though the infection risk during the neutropenic period is significant.
Right.
But if it's due to something like severe aplastic anemia or an aggressive leukemia, then the prognosis is obviously much more guarded and depends on the success of treating that primary condition. So outcomes can range from completely fine to quite challenging.
Okay, depends heavily on the why. Lastly, what are the main dangers or potential complications we need to be aware of with neutropenia?
The number one complication, the main thing we worry about, is that significantly increased susceptibility to infections, particularly bacterial and sometimes fungal infections.
That infection risk again?
It's the central issue, and these infections can be much more severe than in someone with a normal neutrophil count. They can progress rapidly, lead to sepsis, which is a life-threatening systemic response to infection, and require urgent hospitalization and intensive treatment.
So potentially very serious infections.
Yes, absolutely. That's the major direct complication of having too few neutrophils. And then, of course, you also have potential complications related to whatever underlying condition is causing the neutropenia.
Right, the primary disease has its own issues too.
Exactly. They often go hand in hand.
Okay, so just to quickly recap them. Neutropenia. Low neutrophils, meaning a higher risk of often serious infections. It's got a really diverse range of causes: meds, chemo, infections, autoimmune, bone marrow issues, genetics. Diagnosis starts with that FBC, the blood count, then often a blood smear, and maybe more tests like a bone marrow biopsy to find the cause.
Spot on.
And management is all about tackling that underlying cause if possible. Maybe using GCSF to boost counts, being super vigilant about infections and treating them fast, and taking steps to prevent them.
That sums it up perfectly. And, while hearing you have neutropenia can definitely be concerning.
Understandably.
Yeah, but understanding what it is, why it might be happening, and how it's managed is, I think, a really crucial first step. It empowers you in managing your health.
Absolutely. Knowledge is power, as they say. So while we often focus on the invaders our immune system fights, understanding when our own defenses are down, when our own army is understaffed, is just as critical.
Well said. And if you listening want to dive deeper into this topic or revise other key medical conditions, especially for exams like the MSRA, definitely check out pastthemsra.com. Loads of great resources there.
Yeah, pastthemsra.com is fantastic. And also, don't forget freemsra.com for even more excellent free materials to help with your revision and learning. Definitely worth a look. Thanks so much for tuning in to this deep dive.